It's really my pleasure to interview Dr. Andy Burgess in Houston, Texas, one of the most famous orthopedic trauma surgeons in the U.S. and perhaps in the entire world. I had the great pleasure of having him as my fellowship director at Shock Trauma in Baltimore, Maryland. Tell us how you got involved in orthopedics.
I started college as an aeronautical engineering student, and you do ME mechanical engineering before that, and I flunked out of college. And it was a fairly tough school, and at Cornell, and worked a little bit and got back into a smaller college in the Midwest, and graduated, still interested in engineering, but developed an interest in medicine and thought that's what I wanted to do, but I'd blown it by getting thrown out of college. So I had to go to graduate school for 4 years and show them I was serious. And I was in an anatomy program funded by NASA, by the way, and National Science Foundation, and was lucky enough to get into the second year program at College in New York. And from the beginning, I had this interest in mechanics and interest in biology. And I taught gross anatomy, and the combination of understanding anatomy, all of us that were going to be anatomy professors took quite a bit of physical anthropology. I started thinking I wanted to be an orthopedic surgeon in medical school, and stayed where I was in Albany, New York, and did my residency there, and went into private practice. Even though I had an interest in trauma, decided to stick with ortho. Was in private practice for a while. My partner had a substance abuse problem, and I left after a year and a half, and my old buddy Bruce Browner was running a trauma unit, and I knew I was interested in that. Moved into a fellowship in sort of the first week in April in '81, and Bruce was running shock trauma in Baltimore, and I was in heaven. The volume was immense. I was the only fellow, and a year later I was the only attending. In the meantime, when I was a resident in Albany, I took a course in Switzerland, and one of the early AO courses, and said, these folks have the way. They must be that smart. And the education there came through, and the enthusiasm. And when I got back to my fellowship, I tacked on an extra 3-month fellowship with Tom Rudy in Switzerland, in Chur, following my shock trauma fellowship. And the early version of shock trauma in 1980 and 81 and 82 was a gift. Really, Baltimore was the first, or maybe the second, really true what was going to become level 1 trauma centers, where polytraumatized patients arrived in one place. And the gift to an orthopedist early in a career that was thinking of trauma was in the physical plan and then the politics. We were all fairly well trained, but a high volume of blunt trauma and some penetrating was delivered to one site. And we took over an abandoned hospital. That's where we started. That was tacked onto the University of Maryland system. And the resuscitation area was across the hall, 10 feet away from where we operated. Patient would come in, be resuscitated, 5 or 10 yards of you. A lot of times, if they needed an opinion in a musculoskeletal injury, let's say a blunt pelvic trauma, you remember there was no CAT scan yet, no interventional angio, no ultrasound. It was a patient with a blunt trauma to one part of their body. Let's talk about the pelvis. A plain film. Often the EMT that had delivered them was still in the room cleaning their stretcher up or something. They asked you to come over and physically examine something that confused the general surgeons. We had no ER docs. It was general surgeons and anesthesia running the resuscitation. And you were there, not called up from an ER 2 hours after workup started, but walking over within the first 10 to 20 minutes, getting your hands on something, looking up at a plain film, and getting a set of vital signs, hearing a little bit about the history. This was a big T-bone or something else from a helicopter pilot or a medic that had been on the scene, ejection from a vehicle. So you had all this piece of data. And mainly it was your hands, your physical exam, and understanding what a plain film and a set of vitals meant. The gift there was, as new technology was introduced, let's just talk about CAT or interventional angio, we were getting 300 pelvic ring disruptions a year then. For a while, I was the only attending, but we quickly went to 3 of us. But you were there for most of the cases, and you developed this library in your hands and then your common sense. And if you had a little interest in car crashes, which I eventually did and got funded research in it, but basically these pictures started to come together, and most of the patients were physiologically compromised because we truly got polytrauma. Our nursing staff got a phone call, and if somebody had fallen from standing, they weren't delivered to our trauma center. They went next door to our normal ER. So you had pre-selected from a state, the whole state system, the worst cases, the highest energy, the early phases of trauma care where it was your hands, plain films, and also response to the first treatment. And in those cases, massive fluid resuscitation or inland saltwater drowning, as we learned to call it, because we didn't have massive transfusion requirements then. So then we built a new building around that, and you trained there. We kept the resuscitation area close to the OR. We've got orthopedic hands on these patients early on. And remember, as airbags, seatbelts came into the civilian world, and our colleagues taking care of warfighters had helmets and everything, 82% of the patients coming through the door had significant musculoskeletal injury. So those of us that were interested in that were in heaven. And even though it was hell on your personal and family life and threatened all of that a bit because of the hours, there was a little bit of light at the end of the tunnel, because in our case, and you were there, they built us a new trauma unit. It got better. They gave us the budget to recruit excellent partners, most of them. And all the cliches about hiring better than yourself are true. And people like Bobby Brumback with a mind as sharp as I've ever seen in designing studies, and Attila Poca with an attitude that beat all get out, and hands of gold. You'd find Attila doing an open tibia and then come back 2 hours later, he'd be screwing an odontoid back on. And so that's how I got interested, and that's how I stayed interested. And the second fellowship I did before I showed up in Switzerland was with Tom Rudy. And I will say that the energy was a little bit lesser there, but the reason that was such a gem to me is I had been out in private practice for a year and a half, and then had a year-long trauma fellowship before I arrived to do my European fellowship. And here I had this master surgeon teaching me finer points, and I don't want to call them tricks, that's cheaper, some of the finer points of soft tissue handling and stuff like that. And because I'd been out there for a while, I felt like I was wearing Velcro. He'd have a point that I would have missed if he was trying to teach me when I was a resident. Do you know what I mean? And a fine point. And I was going through cases where I had a problem, and he would do this fine point, and he'd throw out a little solution to this problem, and it stuck to me, and I remembered it because I knew it was relevant. I wouldn't have known its relevance 3 or 4 years before.
Tell us about, how did you
articles
published, the Young and Burgess classification? And
yeah, well, some of our best stuff is on the femur, where I'm the 12th author or something, but the vision we had was volume shared amongst, in our really critical growth years, 3 people, and then the fact that nobody was threatened by the other's excellence. So there's a long way to answer this, but we were all pretty good surgeons. And none of us were stupid, but it was obvious Bobby Brumback saw things very clearly. And Bobby and I were pretty good as surgeons. And so it didn't threaten Attila and me that Bobby was the smartest. And it didn't threaten Bobby and me that Attila was the best surgeon, because we weren't bad, but he was special. And then talking to having my hands on all those pelvises, having a radiologist that obviously is from your town now and was a chief of radiology, but Jeremy Young, who worked at the University of, South MUSC. You often had a fight in those days. It was all plain films. There was no digitalized thing. So we shared an X-ray room with radiology, and so we didn't fight with them. We would have early in the morning and late at night. That was our room to just go over. We went over every case every day. I think you were there for some of that. Whoever was in the hospital, we review their cases. And for instance, on Young and Burgess, we loved the Toronto classification, Marv Tile and George Benel, before Marv got into his second AO type classifying, and it seemed to make sense, lateral compression, AP compression. Jeremy and I would be sitting there, and I'd have a feeling that somebody would be tapped in a low grade lateral impact, and somebody be really hit hard. And somebody might be hit by a flat fronted vehicle and truly run over. When you hit with a flat fronted vehicle as a pedestrian, you don't do a fender vault or a hood vault. You get thrown out in front and occasionally run over, like as you do in a construction site. And we'd classify them. We were using Pennell and Tiles classification. And so it was totally their vocabulary we used. And Jeremy said, and I forget who said it first, but he came to the idea of publishing it. He said, that one looks like a little higher, a little more energy hitting from the side. You call that lateral compression? Yeah, that we do. And so we started to type them, and it became relevant. And we noticed I'm going to go to lateral compression type 3s. I don't mean to get the specifics, but where it's crushed in on one side and open book on the other. And you said, well, he was hit by a flat fronted vehicle, and I was there when we cut his clothes off, and he actually had tire marks, on him. It is logical that then that appeared to sweep the pelvis to one side. And we eventually looked at 300 and some odd pelvic ring disruptions, including some acetabuli. And sure enough, there's some pretty heavy injuries around your pelvis, but if you take a look around, those LC3s don't have much other bodily injury. And to really understand how that happens, you have to go over to the medical examiner's office and see the people that got crushed where it hit them in more of the two spots. They were not survivors by definition. Yeah. That's what happened. And I had a partner in Bobby who had the unique ability to ask a question simply that we all wanted to know. Well, locked femoral nailing was brand new. We had some that didn't do well. We had the humility and the common sense to say, where did we make mistakes, and identify pre-op, intra-op, and post-op of that, and then second questions logically. We weren't ashamed to ask simple questions. Can you weight bear early on them? Do you have to lock them at both ends? We also sucked up the knowledge of others. We were told in locked nailing that you had to dynamize. If you were locked at both ends, you had to dynamize at 12 weeks or you're going to make a non-union machine. And we all would gather, in our case, in Napa, and the chief of trauma, Don Wiss at LA County, was there and said, oh, my agricultural workers and my bikers never come back for follow-up. And I was sure for a while I was creating non-unions, and we were listening, and Bob Winquist was there, and a bunch of us just nailing a lot of femurs. And he said, they all heal, by the way. So that's a myth coming from the European professors. And then Bobby designed an article to take a look at that and showed essentially that was true. So it was, from pelvic fractures and saying that looks to be a little more energy. And then in the end, we snuck in 400 car crash reconstructions, where I could tell you with each one of these cars, while I'm looking at their orthopedic injuries, what the delta V was at the time of impact, change in velocity, and what the PDOF, or principal direction of force, is, and musculoskeletal injury inside that place, place being the inside of the car, gave you a very good picture of how it was hit, how the body reacted, because the hard tissues tend to break in the patterns we're all familiar with. And we would relate that to how the car got crushed or broken, or how the ejection went in somebody that left the vehicle. It just all seemed to make sense. And that's where some of the articles came from. It was humility of the three guys, recognizing other guys' expertise, the common sense you get. And then I honestly believe that still from the beginning, Langdon, even when the guys joined me after the first year, we still had another couple of years in that environment where we were seeing the patients. So you'd see a pelvic injury and you say to the general surgeon, let me stabilize that. Depending on the decade, that would be a sheet, a binder, an X-fix. I brought sterile X-fixes into the resuscitation area, all that stuff. And they'd say, no, that we're going to do the laparotomy. And you'd physically have almost an altercation. And what I did the first year and the other guys did, we'd scrub in on the exploratory lap. And so when we saw it, we were correct, the blood was on the retroperineum, we'd be right in the surgical field making fun of our colleagues. And when we occasionally made the wrong guess, we were embarrassed right in front of our colleagues. But you got much more savvy and much more predictable if you were there during the first, physical exam of the patient within minutes. And a plain film would tell you a lot. You'd see one of those APC3s, type and cross them for 6. Who are you? Is blood pressure stable? Yeah, it's not going to be in 5 minutes, so let's go. And they thought you were a wizard and you were just applying common sense.
Tell us a little bit more about your trajectory through the AO.
Well, it's not what I had hoped at first, but because I came back and I was devoted. And then, you know, I had my little run in Albany. And when I came back for my last couple of years, I had been the only guy that had been to the Swiss course. So I got called in for every plating, every nailing. And nailings were open up the femur and sending a guide wire up north and banging it through the piriformis and retrieving it from the buttock, then reducing and coming down, because we didn't have image intensification or anything else. And occasionally it was sawing a nail for length. And then I got the nickname AO Andy back at the shop when I came back to shock trauma, and they put that over my door in the old building. And my office was in a trailer placed on the roof of the building, regular, as in for freight and those that put on board ship. And they piped in AC and electricity. That was my office. But it said AO Andy over the door. So I was a purist. And we were down the street from Paoli, Pennsylvania. But the AO royalty, they were concentrating on Seattle, and for good reason. I mean, Ted Hansen and those guys were there. And by that time, we always wanted to be as good as Harborview. And we that was where we felt we were a solid number 2. And in my heart, I felt a little better than that. But publicly, I certainly said we were a good number 2. But AO paid us some attention. We taught the pure technique. Sometimes we fought them on plating. We never had any issues with. We occasionally had issues on their thoughts about nailing and external fixation. They were sometimes a little slower to change in that they were so far ahead in plating. And as I noticed on my fellowship, we plated most everything. And there were some that, you know, that was the culture there at that time. The problem was, they were so damn good surgically that plates did very well, and in my Swiss fellowship. And so I think we kept a pretty pure technique. We were good platers. We then inherited an upper extremity surgeon who was technically gifted AO techniques and added a couple of his own, and Andy Egelsater. And they would try out new things, early unreamed nails, early RIA things. We were a handy place down south of what we considered Paoli, our contact. And I had money then, a budget that I could keep. Nobody wanted trauma, so we all joined the same professional corporation. So it was trauma orthopods, general surgeons, neurosurgeons, anesthesia, and critical care docs, and infectious disease. We were all in the same professional corporation. And you could, we didn't earn much in our base salary, but if we had a bit of a bonus, we could keep it, and then there was a limit on that. And then it became yours to spend. So for an X year period, and I don't remember what it was, but it was more than 5 and maybe as much as 10, every Maryland resident went to the Swiss AO course. And for a few years there, when I had a big bonus I had to spend, many of my Maryland residents went to the advanced AO course a second time in Switzerland. So we became pretty good consumers of the product, both the basic and the advanced courses. And I think alums ended up pretty well thought of within the AO fraternity, and ended up as course instructors and stuff like that.
Fortunate enough, you helped me get over there and go see Tom Rudy and Peter Botter and Errol Cherney and Christian Creddick, and I mean it was and Emile Lotinel.
Yes. We flew Emile over to Baltimore. We operated with him.
Yeah. How do you feel about your experience versus what you see currently?
Well, one thing I have to fight to make sure our kids, since all of these have changed a bit, and this is going to sound peripheral, I have to fight for our kids when they want to start them earlier and early into orthopedics. I have to make sure that in their first year, the courses they take that are non-ortho, or the electives they do, have value to orthopedics. Some of them just didn't, but some of them did. Plastics, radiology, and actually being active in a good general surgery trauma service, learning how to resuscitate a patient, get in a belly now and again, and work in an ICU and do an H&P on a polytraumatized patient from a general surgery point of view. I think that's as close as I can to give them that old thing where they're called in early, was to make sure that at least in their first year, they really are. And when we first came to Houston, for instance, we were busier than we think we're the busiest level one in the country. We're busier than LA County, busier than Northwestern, busier than Harvard. At that time, Northwestern had 9 residents, LA County had 10, I think, and Harvard had 12. We had 3. So our residents were hopping, and they actually spent a lot of time just living in the ER. And what I noted was they were asked to see. It wasn't quite as easy as I had it walking across from the OR, but they had to be there because they almost never left. And so they were called in early on several of the polytraumatized patients, and that sort of happened by the culture of this place. And I thought that maintained some of that gift of being there early, but it was almost by accident. I think they're missing something on that. At the young attending level, I think, you're sitting in your office or you're in the OR, and depending on where you are when a new consult comes in, and many things have been done to those patients and many studies have been generated. And you may be distant even in your clinic at times, and something comes through and it's a call from an ER, 100 yards away and maybe 3 or 4 flights away, or maybe 10. And so I think that may be gone forever at the level I enjoyed. And we try to do whatever we can to substitute for that. I think it's the best I can say.
Yeah.
We're up to 5 residents now. So that's a good and a bad thing. 3 was crazy in this center, but 5 keeps them down where the action is. And also, they almost get as much. I was dead serious when I said fighting for and getting in some of the exploratory labs, because remember, we didn't have mini labs even. We were opening people and exploring them. So if you had a bet on a retroperitoneal contribution to a bleed, you were there to verify it. You were there when the laparotomy was done, and you didn't have a CAT scan that showed it. And you were fighting in the early days because we were all getting used to what a pelvic fracture really meant, and the downside of doing a laparotomy when it wasn't necessary. Often we'd get in and we'd see a couple of small mesenteric bleeders, but the guy was bulging at you, and you'd had an animated discussion of somebody where the pathology was. And then as the technology came in and we learned to stabilize things, the things small points. Well, you wrap a pelvis up, and because we knew how to have interventional angio, but interventional angio is more exploratory for non-emergent conditions. So it's some distance from the ER, the first ones. And you send a patient over and you don't escort the patient, and you forget that some tech or some general surgery intern is going to take your stabilizing force off, your binder, your sheet, just do something. That's one of the reasons we actually liked X-Fix a little more than I think is common sense, because it was harder for them to screw it up, and you just had to make a low profile one to fit into the scanner. But so that you learned that you send them over with an escort that can't screw it up. And because every time you'd send them over in the first days before you stabilize them, the physical act of moving a patient would often destabilize them. It was as if they bled and their first clot sort of stopped, and you caught up with them with a couple of units of blood and a fluid challenge, and you moved them onto the table, a gantry, for their next phase without any stabilization on. And all of a sudden there'd be a code blue or whatever you'd call it in the X-ray suite, and you knew what it was. They'd busted loose because they were being moved around without being stabilized. So there was all kinds of stuff to learn, and enough volume where the pattern of these things really taught you a lesson.
What advice would you have for surgeons coming out of fellowship? What should they be looking for?
Volume, and then the rest sounds like cliches. A boss that's truly gets what he's getting in hiring a woman or a man that is wants to be a traumatologist. I would suggest being very wary of, hey, we have a private group here that's going to do some trauma. We're hiring you because we can't do it all. You'll be our traumatologist in our private group. You'll eat what you kill. Don't do that, because it's hard to make a living that way. You're going to need a title of chief of trauma or somewhere they can supplement your income. But basically someone that's committed to give you a place to work, because I think the men and women that go into trauma nowadays, I think they're the best of the orthopods, and I love orthopedics. I really do. And they can take anything for a while. And if they can't, they shouldn't be on the playing field. But there's got to be light at the end of the tunnel. And the main repetitive thing about retaining people is give you a place to do the work. The crime, time and time again, and I know you know because you've got some gray hair. It's been the place is full. You've got the energy and the personnel, and there's no place to get your work done. Well, once in a while, get over it. If that's the pattern, and every night you're getting home late to a family that you love, to some hours that you really have had to surrender during the week because you've been doing emergent stuff. If your first job perpetually gets you home 3 or 4 hours later than it should, that's got a clock on it. In other words, don't be a whiner and pick a cliche about being a problem solver, not a problem causer. But you have to be part of solving that issue and or have a boss, if you're the one hired, that's committed to helping you solve that issue so that you can get your work done. It's just the nature of the beast. And there's just too many times I've sent people out and they haven't lasted because they didn't have a version of that, a commitment to it. The easy way to say is a trauma OR. It's in the optimal resources doc in your American college, but it's serious. And I sound a little dramatic about that, but the versions of that are what's, I think, short-sheeted a lot of careers. So that's it. And, we're not all about money, but being compensated well for what you do. And you're not going to make that on what you collect. We hit 19%. We're lucky any place I've been at collections of the trauma service. But the hospital, if it's a decent enough to employ you as a traumatologist, should be doing fairly well. If it's chosen to participate in trauma care, there should be some state funding, and the hospitals usually do well and can supplement or title you so that you have a decent income. You didn't pick pediatric ortho or trauma to get rich, but you can't be a sucker either. And then partners that understand what you do. I think depends. If you're in with a group of traumatologists, choosing a cast that gets along. That's my favorite thing late in my life, is to assemble a group, not just of excellence, but that really complement each other. And we've gotten lucky a couple times at that. And Houston being extremely lucky that way. And so that's my selections of, or keeping, if you're in a private practicing, it's good. It wouldn't be the worst thing to be the second one to take that job. Because if you're replacing someone, they've probably learned something on it when they took the first one. And they had, I've seen this more than a few times, been involved and close to it myself when I left Shock. But they have this place, and you're just going to eat what you kill, and good for you. And the numbers don't look so good. And all of a sudden, you're on a lot, and which wouldn't be bad if you either had a place to work or we're getting compensated fairly. The combo of having neither is probably, it depends on the individual. It might be worth it if you are living geographically in the thing that makes you and your family happy as hell in it, and then you're willing to work longer on the project. If everything else is not quite right about the place, we get more mileage out of alums of that place going back to a place they already love. They're willing to put up with an extra couple of years of hardship to try and solve the problems. And frequently they do, and they stay and they fix it. And sometimes they don't, and they have to leave. But if they train there, they go in with a little bigger heart they got what's wrong with it, and they're willing to stick an extra year or two, make it 3 instead of 2, or 5 instead of 3. That's a long answer. I'm sorry, but those are the failures.
Maybe just share a little bit about what you like outside of orthopedics. I know you like to go to Maine, and you like cars, and
as I'm slowing down here in Houston, I get more and more time, and I've had a family house in Maine since my parents retired there in the 70s, early 70s. And I like the Maine coast, and I have a little boat, and I just love being on the water up there. I'm not a fisherman or a lobsterman. My neighbors are lobstermen, but I just like getting out on the ocean. And with a smaller 26, 27 feet boat, that's pretty small, but 29 foot, I guess it is. And so I get bounced around a lot, and watching the Maine coast from both being on the coast and going to the small inlets and photographing that, to be frank. So a lot of photography. We have a transportation museum up there. I think when I retire fully, it's got a lot of folks like me that are retired. Mostly they're for real. They're ex-pilots or ex-car jocks, and they work as volunteers in the museum restoring old vehicles and stuff. I used to do a little of that in my teenage years with some friends, but that would excite me a bit. And so that's most of it. And cars, I enjoy my automobiles. But I don't do many deep mechanics anymore. I did one way long ago, but now I have somebody change the oil even. So it's a lot of work for me to turn the key, or,
Well, I have one last question for you, Andy, and you're a great storyteller. And so maybe you could just give us one fun vignette, fun story from your career.
I got one. You can edit this out too. So I got a call. I was taking a guest out to dinner while I was on call. We were about a block away, and we got a call. It was a pelvic fracture. I think I've told you the story before. And we came back and entered the building from a restaurant in downtown Baltimore. We came up through the waiting room in the new building, and the family was already there. The guy must have been helicoptered in from the suburbs. And I heard them. They didn't know who we were. We were just walking through and had to go through the waiting room area. And they said, they were saying, so he was hit by that car, the guy with his blinking lights on. He must have stopped. Yeah, at least he saw him. And they talk about their family member who was a pedestrian struck. And he said, yeah, it was that big Ford Explorer, the Eddie Bauer. Yeah, I saw that green one. So upstairs I go, and the digital films were new, and my crew is sitting around with pelvic films up in the air. And they said, Dr. Burgess, what do you think? And as you remember, and I forgot to tell in the beginning of the story, our pleasure was we trained all the Bethesda, Walter Reed, Union Memorial, Johns Hopkins, and joint disease residents at Shock Trauma. So you remember we had quite a group.
Oh, yeah.
So at nighttime, there was a few people on, and they were looking at these films, and a couple of them were fairly new, and they didn't know it was Burgess, and he had this classification and blah, blah. He claims he knows a lot. And I came up to the board, and they said, what do you think it is? And I said, oh, this is that kind of CFTV. All right, it's a lateral compression, but probably of a pedestrian. And the way that struck, that's a high strike. I probably hit with an SUV. Where's he from? Where'd he get hit? Up there? Oh, in Oseberg, man, everybody's got a Ford Expedition up there. It was an Eddie Bauer model. And coming behind me was the helicopter pilot wrapping up his belt from the stretcher. And he'd been at the scene. And he comes walking across, and he heard me said, hit by an SUV. And I feel him stop to my side, and he's going, yeah. And he's still rapping. And he's looking at my team that this legendary guy has gotten that correct. Then I called the model and the color that hit this guy and created his pelvic fracture. And these young doctors went, holy crap. And obviously within 10 minutes, they figured out we were talking BS. But that was the sweetest 10 minutes of my life, where they thought this wise old man had not only put a classification on it, but identified the vehicle that did the damage.